joined by Dr. Naaheed Mukadam, who is a senior research fellow at the Division of Psychiatry at UCL. We've had several people from UCL Psychiatry today. Did I completely butcher your surname then?
No, that was all right.
That makes a change. And we also have Nadine Mirza, who's a postgraduate researcher from the University of Manchester. It is doctor. Sorry, do you know what? I had you down as Dr. Nadine Mirza, and then I took it off because your Twitter
No, it's not doctor. I don't know why it's saying doctor.
It's doctor there too.
Oh my God, it's like aspirational, like one day.
Well, yeah, well, what is it? Dress for the job you want, right?
Exactly. Furnished for the job you want.
Yeah. Well, you're already consultant or professor with that backdrop. Is this your house as well?
It's my parents' house.
I was gonna say that looks like a
very
parent's
nice
backdrop.
Thank you.
Is your dad a consultant or a professor?
He's a doctor, so he's a consultant.
Thank you very much both for joining me. So why don't let's do proper introductions. So Nadine, could you introduce yourself first?
So I'm a PhD student at the Center for Primary Care at the University of Manchester, and I've been doing research around ethnic minorities and specifically British South Asians' experience of diagnosis in memory clinics and how they access those services in the first place. So I started off my research first by looking at the tests that we use to diagnose and screen with dementia and how those tests are heavily influenced by language and culture. So when you don't match the test for culture and language to the population, you get things like people being diagnosed when they don't have it, or their dementia not being detected. So the first part of my research, which was my master's, was working on developing methods to culturally adapt tests for different populations.
Sorry, I'm going to come back in. I'm going to come with questions. So the South Asian population in Manchester that you were looking at, would these are people that have lived here that have lived in the UK for a long time? It's just that culture is still retained in amongst the family and their extended community.
Definitely.
Sorry, carry on.
Yeah. But it's a good point. It's especially because so many of these South Asians, especially the ones who moved here, they moved as young adults. So their culture is very much ingrained in them already. And as can happen with dementia, you sometimes regress to the first language you ever knew and stuff like that. So I worked on okay, we need to address these gaps with the tests. People shouldn't be, misdiagnosed because the test wasn't designed for them. And then from there, as I segued into my PhD, we're like, okay, let's not just focus on the test. What about the services overall? Is the onus is kind of to blame the ethnic minority communities, like, oh, there's stigma in their communities and they don't want outsider help, which is partially true. But for the ones who do seek help, the services are very hard to access.
Well, that's what I was going to ask, because there is that stereotypical response, isn't it? That, I'm not even sure I like that term of hard to reach group. There are this group of people, because I don't know if they are hard to reach. We're just not very good at reach, but is there an issue with engaging services in the population in that population you are researching? What is this like? Is there stigma amongst dementia? Is it closed family? Is it something hidden away, or?
Well, there definitely is stigma. This is undeniable. The whole concept of mental health is still stigmatized in ethnic minority communities and very much so in South Asian communities. But these communities are grasping on to mental health concepts now, especially something like dementia, because when you speak, they all know someone who has it. They're acknowledging it more. They're understanding the biology behind it. And with that, it's more like of course, they have these beliefs that we don't want outsiders to take care of our family. We feel we're responsible for them. If anything, services should facilitate that then. Can we have a relationship with both family and outsider help? And then the actual educational materials that exist in these services on dementia, they're often in English. When they are translated, the translations are very, very poor. It's honestly, like some of the Urdu translations I've seen are the equivalent of like Old English. So imagine like you're reading about dementia, it's like thou, thy, and all of that. I mean, you're not gonna it's gonna be very hard to understand that. So that people are trying to engage with services. They realize they need help, but the services are not reciprocating.
So I'm going to come to you, Naaheed. You're a little bit further along your career. I guess you might have been research. Is this something you've also been looking at for some time? Tell us about your work.
Yeah. My research career so far has been looking at inequalities really in dementia, and that's across the board from the help-seeking pathway to experiences within memory services, and also now more recently looking at prevention and post-diagnostic support. So I'm really interested in what Nadine's saying about her work, and I'd like to hear more about it, because it does seem like it's sort of it's very much sort of complementary to some of the stuff that I've been looking at.
I was going to ask, when you were talking about your work there, so when you talk about differences, are we talking about particular ethnicity differences, or could this be about people with I don't know, that have got low incomes, or different family, different communities, or there's been a lot of talk about kind of traveller communities and things like that. I mean, which population?
Yeah, sorry. So I just should have specified. Yeah. No, so it started off being relatively broad, so looking at minority ethnic groups, and primarily so African or Black African and Afro-Caribbean populations, as well as the South Asian population. And then for my PhD, I focused on the South Asian population specifically, primarily because peer review, when I was trying to do all of it, was saying you really need to narrow this down. So looking at inequalities with regards to ethnicity specifically. And of course, I think, as we've seen from COVID, there's, being from a minority ethnic group has a lot of confounders associated with it, in that, the socioeconomic status as well, and where you live, these are all confounding factors. But I've been very much looking at ethnicity and how that plays a role in, whether you seek help and then you experience help.
So interesting. Obviously, I know, and Dean, you specifically looking at South Asian populations, Naaheed, in slightly different groups. So how did you find that? I mean, is there are people less likely to seek help if you're from one of these groups, one of these minority groupings?
So certainly from my research, I've found that people from minority ethnic groups tended to delay help seeking. So they recognize that that symptoms of dementia are not normal. It's a change in their family member, but there was more of a delay in seeking help compared to the white British population, for many reasons. Partly because not thinking this was an illness that needed to involve a doctor. Partly stigma. Partly the sense of familial responsibility. So that led to the delay in seeking help. And as a result, one of my studies looking at electronic health records found that for people presenting to memory services, that their MMSE scores were lower at the time of presentation, indicating that their dementia may have been at a more advanced stage.
Longer to go.
But that they were actually younger when they were diagnosed with dementia. So they're indicating that there's actually more of a greater susceptibility to dementia amongst minority ethnic groups.
That's interesting, because I saw your work looks at risk and things as well. So suggesting that there's a higher likelihood of getting it younger, but then waiting longer before, so it ends up about the same. You end up both going in there about 70 years old, except somebody's had it longer.
Yeah, that's right. And so when you're presenting later, often the presentations tend to be more in response to a crisis. So it's more distressing for the person with dementia, their family members. And then if you're presenting at a later stage, there may be less that the memory service can provide for you, at a later stage in the disease. So I think it's really important to raise awareness, reduce the stigma, and encourage people to come earlier, so that the diagnosis can be given in a timely manner.
How does that compare to, say, somebody who has a more acute somebody, I'm thinking about memory is this subjective thing that, if somebody hurt themselves in some way, are they more likely, or are they also still less likely to engage with services? Is this something that's unique to dementia, or actually we're talking about health services as a whole?
Yeah, actually, I think so. So maybe acute injury is probably not as similar enough, but for things like diabetes, for example, or other health conditions, there is evidence that actually in South Asians that help seeking is delayed for those as well. So and it's difficult to tease out, whether it's above and beyond that for dementia. Certainly, the stigma around mental health conditions indicates that it might be even worse for dementia. But there is this sort of reluctance for other health conditions as well.
How does that play into your work, Nadine?
I mean, it seems to be exactly what I've
Same in
heard.
Manchester, because your research is in London, Naaheed.
That's right. Yeah.
Yeah. So sort of the same sort of stories you hear from people in Manchester, and they absolutely decide, like you mentioned with the diabetes, they are seeking help a lot later into the progression of these diseases, unfortunately. And I know that for some people, it's sometimes a mistrust in health services as a whole, sometimes due to things like racism and stereotyping and stuff like that.
Yeah,
So,
and that's definitely come out with my research as well. Yeah.
so it leads to not really trusting, the physicians your life is in the hands of.
And I think as well, I mean, you'd like to think, wouldn't you, that family members that perhaps have that kind of second generation of family members that kind of went to school in the UK and grew up, it would be encouraging to engage with services in the same way. But I think the communities retain those cultural differences, and so you can't assume that just because your kids grew up and went to school in Manchester that they'll be as engaged as the middle class white family from down the road as well.
Exactly. I've had, when I was doing public engagement work in community centers, and I would be talking to people of all ages, and it's almost like this passing down of horror stories, like, oh, when I went, this has happened to me, don't go.
When we would, a lifetime ago, I did some work in Slough that was looking at sickle cell disease. I mean, this is very long time ago, 20 years ago, and looking at how they were raising a population to come out for, I can't remember if it was screening or to come out and to look at this in Slough. And one of the things that made a big difference there was when the local doctor was from the same ethnicity or was from the same community, that doctor's services were massively used more than anybody else. And so I don't know if you find that the same. Is this the same with dementia? If your GP is also, from that community, do people trust more do they trust more in that way? Are they more likely to go? Is that something you managed to look at?
Yeah, I think there is that element of trust. I mean, my husband's a GP, and certainly he finds that for treatment of chronic health conditions in his Bangladeshi patients, that he finds that there's sort of better engagement with him, and my patients and people from the community that I've spoken to have said that when they're thinking about going to a memory service, it's really important for them that someone from their culture, someone that they can identify with is there, that that they feel that they'll be be a good fit.
So we've talked about this and carers and things earlier in nursing home staff, but perhaps encouraging people from different groups to work in those services that are supporting the patients in the first place could mean that there'll be more accessed and reduce some of these disparities. Perhaps, I mean, clearly there's a more fundamental science thing going on here. If people are getting this earlier, looking at those lifestyle factors, and I know there is research going on to look at how dementia affects different ethnicities, although not as much, I suspect, as there they ideally would like to be. But this comes back to the point that we made earlier, that we just need more researchers. It's not that to be working on this as well.
I do have an interesting counter. It's kind of, so I definitely have noticed, and I've read the literature and spoken to people, that it definitely helps to have people that represent you in the service. But at the same time, I also met people who said they might be initially quite wary, because what if it's someone from within their close-knit community? And that again comes to the stigma idea, like, oh, what if they tell somebody that I know this information is going to spread? I'd rather not risk
you might lose the anonymity.
You might lose the anonymity. So it's almost a double-edged sword, because when you don't have representation, you miss out on a lot of information. When you do have representation, there is a fear of being stigmatized in your community.
So what changes, I mean, in the research, Naaheed, I'll come to you first. What just a reminder for anybody watching that we do have time for questions, so please do post your questions if you have them. You can do them in the Q&A box on the Zoom, or you can post them in the chat section on YouTube. What's your research suggesting we could do to improve that situation, Naaheed?
In terms of help seeking?
Well, I mean,
or just across the board?
Across the board. I mean, for each of these elements, because obviously you look at both care pathways and diagnosis in care. I mean, we haven't talked much about care here post diagnosis. I mean, we've just obviously been talking about access to Admiral services and admissions to A&E post diagnosis, or accessing support, and I guess even thinking about dementia cafes and things like this, which you just get a sense of won't be accessed as well as they could. What's the research suggesting we could do to improve this?
So many things. So I think starting even at prevention, I think raising awareness about the link between cardiovascular risk factors and dementia, encouraging people to take up their midlife health check, because we know that diabetes, obesity, hypertension, these are all much more frequent in the South Asian population compared to the white British population. And then, so my work on raising, awareness about help seeking suggests that people respond to storytelling. So seeing the point of help seeking, that actually it's something helpful that you're doing for your family member. And the point of it is that you go, you get assessed, and that, it might not be dementia, you could rule it out. And then if it is dementia, then you get the help and support that you and your family needs earlier, which means, you can plan better for the future, prevent crises, and manage your health better. And then I think within memory services as well, I think there just needs to be greater inclusivity, really thinking about the diagnostic tools we use. Are they culturally appropriate? Do they take into account someone's educational background, their language? Are you missing something, or are you giving people from diverse ethnic groups as good a quality service as you are for the majority population? And then once someone is diagnosed, what support and help do they have available, and is it culturally appropriate? Is it being delivered in a language that they can understand? Are you engaging their family members and their support network in an appropriate way? So I think it's really, throughout from midlife, thinking about prevention of dementia all the way through to post-diagnostic support. I think there's a lot more that we can be doing in memory services and in GP practices, and also in raising awareness in the community about these important issues.
It's disappointing it needs raising, isn't it? Because you'd like to think that this is a no-brainer, right? I mean, this isn't the first time that this has been discussed, kind of trying to encourage and support access to health services, whether that is from, your working class population that don't really engage with things, through to different ethnic minorities as well, is getting better. It's sad that we still need to be talking about this. You'd hope it would have been addressed by now, but it hasn't. And it's not just a case of translation. This isn't making your materials available in Bangladeshi.
Yeah.
Which I think is often even that in itself is overlooked because, oh well, that's more expensive, that's expensive, we've got to do translation. What about you, Nadine? How are you? What's your, obviously you're still doing your PhD. What year are you in? I should have asked.
So I'm in third year, but sorry, oh my God, now I'm in fourth year, but third year barely counts.
And are you doing this over 5 or over 3 and you're late?
It was supposed to be 3.5. Then it got extended to 4. It's probably going to go more than 4 now, given everything that's happened.
So you're writing up though. You've got some findings.
I've got some findings, but I'm going to be conducting more interviews. And because a huge stage of the research that I wanted to do, it got scrapped because of COVID. So we need to replace it with something else. Yeah.
So what are you finding so far? I mean, obviously you've told us but I mean, what in terms of what we could do to improve?
Well, Dr. Naaheed really covered everything there is about, like, the outreach that we need to do in communities and the work that we're doing in the health services. A part of my research was also looking at what we need to do in research to recruit and include ethnic minorities, because I was reviewing the literature. I did a systematic review on this, and the representation of ethnic minorities is very poor across UK-based dementia research, because obviously it's not mandatory here to recruit ethnic minorities, but then the products of that research is being applied to populations with ethnic minorities. So I think we need to train researchers to, again, it's that whole, oh, they're a hard to reach population, they're very hard to recruit from. But how are you recruiting? Are you going, is it enough to say, oh, I went to
default, is it? I think that's
it's not going to happen.
You are going to have to, if you want to increase ethnic minorities in your research studies, you are going to have to go out of your way to try.
Yeah, absolutely.
You can't just put out an advert and people will apply. And so it has to be a concerted effort to do that.
Yeah.
And you get a sense that, I don't know, do you think people are just going, oh, do you know what, recruiting's hard enough without
doing this? But I think in a way that means your research is compromised, because then you see in the paper, oh, we can generalize. No, you cannot generalize this to the population. And you see people, they say, oh, we went to such and so community center, we gave a talk, we gave out flyers. But what we've known time and time again is going in once isn't enough. You need to go there. You need to establish trust with these people. You need to, like Dr. Naaheed said, apply that storytelling concept. Listen to them first. Give them what they want before you start taking them for your labor. And similarly, this is such a small thing, but again, like it comes, translation is not enough. I was making information sheets, and when I translated them into Urdu, just because there are some words you cannot translate directly into Urdu, like encryption. So you have to literally explain it in like 2-3 sentences. And my 4-page information sheet became a 9-page document. And I was thinking, nobody is going to read this. They're not going to want to. They're not going to care if it's in their language, and nobody is going to read it. It's going to put them off immediately.
So, I mean, does that mean could ethics panels, for example, help with this? They could be more understanding. Are there enough? Because I can imagine that there are very few people from ethnic minorities sitting on ethics review panels either.
I genuinely think that's the case, because I had to use this argument because I really simplified my language. Instead of saying confidentiality, I literally explained it. I really simplified it, and I created a summary version as well. And they sent it back to me, and they said that since you've already translated, we don't see the need for you to have such easy terms. Why can't you still use the difficult terms? I'm like, that's very simplistic thinking. You need to understand that population is not going to understand what you're trying to ask of them, especially when you're working with elder South Asians with dementia. They're not going to understand. It's going to be very confusing for them.
Wow. Well, I mean, we're out as ever. We're out of town, and I feel we've only just touched the surface of how this conversation could go. Because also as well, there are so many other people that you'd want to reach through this, and I feel the differences are there. So I hope there are opportunities for you to both collaborate. I don't know how much this is talked about in other conferences and in other venues, but it's an important topic that you feel, I definitely feel needs more exposure and more coming together of minds to try and address this, and maybe learning from other health services as well about how they've engaged. Thank you very much, Nadine Mirza and Dr. Naaheed Mukadam, for joining us today.
Thank you so much, Adam. I think it's a really wonderful thing that you're doing, and I'm impressed that you're still going so many hours into this this chatathon. But hang in there.
The coffee's definitely kicking in.
That Red Bull.
Thank you so much.
Thank you both very much for joining. Please do keep up the good work and keep applying for those grants and making that money work, because you're putting it to really good use. Thank you very much.